Jake is a 58-year-old retired postal worker who has been on your floor for several days, receiving plasmapheresis every other day for myasthenia gravis. Before this admission, he had been relatively healthy. His medical history includes hypertension, controlled on metoprolol, and glaucoma, treated with timolol, which is an ophthalmic preparation. About a year ago, Jake started experiencing difficulty chewing and swallowing, diplopia, and slurred speech, at which time he was placed on pyridostigmine, which is Mestonin. Recently, Jake was diagnosed with a sinus infection and treated with ciprofloxacin. On admission, Jake was unable to bear any weight or take fluids through a straw. There have been periods of exacerbation and remissions since admission. So Jake's wife asks you, what may have caused my husband to get worse? What explanation would you give her? The antibiotic Cipro that your husband was given for a sinus infection can cause profound muscle weakness in patients with myasthenia gravis. There are other antibiotics that would treat the sinus infection without causing the muscle weakness. It's important for all healthcare providers to be made aware of underlying disease processes when they're ordering medications or treating individuals. Okay, so I can see this lady getting really upset if she got Cipro was given to her husband and it was revealed in the health history that he had myasthenia gravis. Perhaps it wasn't, so we're going to have to go with that right now because there's a big dilemma. Okay, so next you're visiting with Jake's wife and she tells you that she doesn't have a lot of information about MG and she'd like to know more about it so she can feel more comfortable talking with her husband. What do you want to tell her? Well, we can tell her that it's a chronic disease. It affects the transmission of signals from the nerves to the muscles. And it's believed that antibodies are built up by the immune system that block the transmission. Therefore, that makes this an autoimmune disease. The muscles can't work very well, and that is exhibited by that muscle weakness. It usually affects eye movement, facial expression, chewing, swallowing, speech, breathing, and head control. And the muscle weakness increases during activity, and it improves at rest. MG affects people of all ages and ethnicity, and women are affected by a 3 to 2 ratio, And the highest incident is seen when women are in their 20s to 30s is when it's usually diagnosed, and men are in their 50s to 60s. It's not directly related to a gene. It's not inherited. It's not contagious. You want to make sure that she understands all that. So you can say it's a chronic condition that's characterized by remissions and exacerbation of fatigue and weakness, primarily in the muscles innervated by the cranial nerves, as well as skeletal and respiratory muscles. It's an autoimmune disease of the neuromuscular junction. It takes many forms, from mild disturbances of the eyes to rapidly developing generalized weakness, and it can actually lead to death from respiratory failure. Now, however, you're not going to tell her all that right away, but you want to explain to her the basics of it. Jake's wife asks you to explain what to expect in terms of signs and symptoms of her husband's illness as it progresses. So what do you want to tell her there? Okay, we want to say that it comes on gradually, although it can progress rapidly with respiratory infections or emotional upset. How fast it actually progresses varies from person to person. Early symptoms in most patients are ptosis and diplopia, but pupil response to light remains normal. Next, the muscles to be affected are the facial, the masticator, speech, and neck muscles. So when the patient chews food, they become tired and they have to rest. There's many problems with managing saliva because of the difficulty swallowing. There's generalized weakness that develops in approximately 85% of the patients. Muscles of the arms and the legs, diaphragm, and neck are affected. A myasthenia crisis exists when the intercostal muscles and the diaphragm are involved, and breathlessness and dyspnea is present. The muscle group affected tend to be weaker after use or towards the end of the day when the patient is fatigued. So the motor manifestations that we see is progressive muscle weakness, which is proximal, and that usually improves with rest. They will have poor posture, ocular palsy, so their eyes actually have a jitter to them, ptosis. They may have weak or incomplete eye closure, diplopia. There might be respiratory compromise. There may be a loss of bowel and bladder control and fatigue. The sensory manifestations are muscle achiness, paresthesia, decreased smell, and taste. So Jake's wife goes on to ask how the disease is diagnosed. How do they know my husband has myasthenia gravis? And what do you want to tell her? Well, diagnosis of MG is based on history, physical and neurologic examination, and lab testing. The patient usually reports that specific muscles have become weak with activity and that they improve once they rest. It does not affect reflexes, coordination, or any sensory perception. Confirmation of MG is based on the results of anticholinesterase test, antibody titer for acetylcholine receptor, and nerve conduction test, which is a repetitive nerve stimulation, as well as single fiber EMG. So the anticholinesterase test is the drug they most commonly use is Tensilon, because it has a rapid onset of about 30 seconds and a very short duration, which is about 5 minutes. What they do is they administer the Tensilon IV, about 2 milligrams. If there's no adverse symptoms appear, another 8 is given. If there is improvement in the muscle strength from a previously weak muscle, and that improvement lasts 5 to 10 minutes, the test is considered positive. And I believe there's a Voki out there that you can listen to about this Tensilon test. The other thing is the antibody titer for acetylcholine receptor, and that is conducted by assay of blood, and 80 to 90% of the patients with generalized myasthenia, the level of acetylcholine receptor, antibody titer is elevated. In the repetitive nerve stimulation, electrical shocks are delivered to a nerve at a rate of 3 per second, and the surface electrodes that are placed on the skin over the muscle record electrical potentials. A rapid reduction of the amplitude of the muscle potential is considered positive as well. The single fiber EMG is detect delay or failure in the neuromuscular transmission in pairs of muscle fibers supplied by branches of a single nerve fiber, and it's about 90% sensitive in confirming MG. Once again, these are these little tests the neurologist does, little pain-invoking ones, as is that nerve conduction test. The mediastinal MRI or CAT scan, they use that, they're looking for a thioma, which is a tumor of the thymus gland. And they're looking for, because many people who have myasthenia gravis have a thioma. So Jake's wife goes on to ask, what are some options for treatment of MG? And how should you explain the different treatments? Okay, so there's different therapies that are available that will help reduce the muscle weakness. Most people have good results from the treatments. The 4 options are useful for the treatment of MG are anticholinesterase drugs, immunosuppressive therapy, plasmapheresis, and IVIG, and thymectomy. So after the diagnosis of MG has been established, individual management is developed, and since there's no single treatment plan that's effective for everyone, the quality of life is the goal, and to keep the patient as symptom-free as possible. So, let's see. If we use anticholinesterase drugs, their first line approach for the management of MG, they don't treat the underlying disease. Prostigmine is the most common drug known, or pyridostigmine is the other one. And they help improve the nerve signals to muscles and increase the muscle strength. Immunosuppressive therapy, if they didn't respond well to the anticholinesterase drugs, long-term corticosteroid can be tried. Prednisone is typically the one that they use. Produces improvement or remission about 70 to 80% of the time. Cyclosporin or Imuran may also be used to suppress the production of abnormal antibodies. Plasmapheresis. Well, we talked about this in class a little bit. It's a plasma exchange where they take circulating antibodies, especially the abnormal antibodies, they're removed from the blood. So it's pulled out of the plasma. It does not treat the underlying abnormality. It does not stop the production of the anti-receptor antibodies. It doesn't do that, but it pulls it out of the blood during the treatment. It takes 2 to 5 hours to complete, and they use the antecubital vein. They may use a shunt if there is a shunt has been established. And the indications for plasmapheresis are to stabilize a patient who's in a myasthenic crisis, or to serve as like a short-term treatment before the patient has, if they're going through a thymectomy. An improvement in muscle strength is noted usually about 1 to 5 days after the first plasmapheresis treatment. The IVIG temporarily interferes with the immune system's ability to damage the nerve muscle junction, and indications for use of IVIG are the same as for plasmapheresis. So it would be short-term treatment if there's a serious relapse, a serious exacerbation, and improvement usually is seen within a couple days. A thymectomy is the actual surgical removal of the thymus gland, and it's done in persons who have tumors, myasthenia gravis patients who have tumors, as well as those who do not have tumors. 80% of patients experience improvement in their myasthenia gravis after the surgery, and an additional 35% have a drug-free remission after the thymectomy. So what factors could predispose Jake to an exacerbation of his illness? What's going to make it worse? Infection, surgery, stress, increased physical activity or hard activity, exercise, overexertion, any type of sedative medications, enemas, poor diet, a strong cathartic. So then Jake's wife asks what the physicians and nurses watch for while her husband is in the hospital, and how do you explain these activities? Okay, well, we're going to look at respiratory function by auscultating and observing. We're going to evaluate the respiratory tests such as tidal volume and vital capacity. We're going to look for unwanted signs, side effects of any kind of drug. So is there any excessive sedation, decreased respiration, agitation? We're going to assess for the strength of all the muscles involved, the respiratory rate, rhythm, quality, abnormal breathing, that kind of thing. We're going to listen to the quality of voice, assess hand strength and equality, assess leg movement, look at his eyes and assess his extraocular muscles and ptosis, as well as assess his neck muscles and the ability for him to hold his head upright. Let me see here. I wanted to tell you also about on our nursing assessment that when we're looking at this individuals who's lost their ability to chew, swallow, that type of thing, we're going to watch how long it takes them to eat. And does the speech or swallowing worsen over the course of the meal. If we medicate this patient with pyridostigmine about a half an hour to 45 minutes before meals, is the swallowing improved? We need to observe for that. Is the patient coughing while they're eating? They're at risk for aspiration. Is there a nasal regurgitation with fluids or foods? And can the patient eat or chew meat and breads, things that are difficult to masticate? So our plan would be to observe and monitor them. We want to do calorie counts, fluid balances, watch their weight, their temperature, listen to their lung sounds. We're going to check for aspiration. As worsening occurs, we're going to discuss with the patient whether or not they want an NG tube, a G tube, a PEG tube. We need to get speech and language pathologist in, or to do a swallow assessment, swallow studies. We want to look for silent aspiration. Jake's wife wants to know when he'll be able to come home. So how are we going to tell her about that? So most patients are managed at home, those who have myasthenia gravis, once the crisis is resolved and the treatments are completed and we've got the meds optimized. You want to explain that he is going to continue to need assistance once he's home. Discharge planning is going to involve working with and teaching Jake and his family members who are going to be involved with his care at home. Social services will become involved and identify needs and arranging for community resources. She then asks you what information she will need before taking her husband home. So both of them, Jake and his wife, need to understand the dose and the purpose and potential side effects of his medications. They need to take the medication with a small amount of milk, bread, or crackers to reduce the risk of nausea and vomiting or gastric irritation. And we want to have them to avoid taking their meds with coffee or fruit juice. You want him to take the meds long enough before eating a full meal to maximize the strength of muscles for chewing and swallowing. So that's 30 to 45 minutes prior to meals. You want him to eat a high protein, high carb diet, take small frequent meals. We want him to avoid fatigue. Any over-the-counter medication should go through the physician, and they need to understand the difference between a cholinergic and a myasthenic crisis and know the signs and symptoms of each. It's likely that he should have, he should have for sure, not likely, portable suction at home, as well as an Ambu bag, especially if he is a patient who is prone to crisis, and they both need to understand how to use it. He needs to wear a medical alert bracelet to identify himself as a myasthenia gravis patient, and should carry a card stating his name, number, telephone number of the physician, etc. He needs to eat slowly and select a very soft diet if he has difficulty swallowing. Relapse of symptoms can be caused by infection, extreme temperatures, excessive exposure to sunlight or ultraviolet light, and emotional stress. They need to schedule adequate rest periods during the day. He needs to pace himself, set priorities, plan ahead. He needs to avoid fatigue. He needs to wear sensible shoes to minimize any weakness and loss of balance, and not to drink alcohol at all. Family members or people who live with someone with myasthenia gravis should have a CPR education as well. So Jake's wife then goes on to ask, what's the difference between a cholinergic crisis and a myasthenic crisis, and what do we want to tell them? Well, a myasthenic crisis is a sudden relapse of the myasthenic symptoms in a patient with moderate to severe myasthenia or generalized myasthenia. A cholinergic crisis is an event precipitated by toxic effects of the anticholinesterase or cholinesterase inhibitor drug and its subsequent side effects. So it's really over medication. The a cholinergic crisis is due to over-medication. And there is such a thing as a mixed crisis that's indicated here on this chart. So what are we going to see in a myasthenic crisis? We're going to see increased pulse, respirations, blood pressure goes up, anoxia, cyanosis, so difficulty breathing. ABCs are having problems here. They may have bladder and bowel incontinence as well, and no cough or swallow reflex. That's with the myasthenia crisis. The cholinergic crisis is more GI related. It's nausea, vomiting, diarrhea, cramping, blurred vision, facial twitching, pupillary miosis, and their blood pressure will go down with the cholinergic crisis. So there's quite a difference between the two. Finally, what supportive measures can you suggest to Jake's wife that she can undertake or arrange on behalf of her husband? There it is. Living in the community after being diagnosed with MG is the support of the knowledgeable family and friends. She might take him to the support group, that he stays on his medication and adheres to the guidelines. She spends time with a neurologic nurse, a social worker, PT/OT to understand what parts each of them plays for the patient. She needs to be aware of the events that might trigger an exacerbation, how to conserve his energy to avoid any fatigue. They both need to understand all of these things. And here's some great websites that you can provide her about myasthenia gravis.